Whenever you're ready.
Okay, folks, we're going to start up. I apologize that we don't have a quorum today, so we won't conduct any business that requires a vote. However, what we will do is at least cover some topics so everybody has the information, and hopefully we can encourage more people to dial in as we move forward in the future. Chris is actively working on making sure we can get more people to dial in, and hopefully things will go well. That's not going to cause an explosion or something? No? Okay, good.
Speaker.
All right. So we will not do anything requiring a vote. We will vote on motion to approve minutes for March in May. And let me just note.
Mike, do you want minutes or not?
What?
Do you want minutes or not?
No, that's a great question. Rich,
We're at 6 right now.
we have no, we're close to a quorum.
7 is a quorum of your group.
7 is a quorum. So we have to conjure somebody up from somewhere.
Want to call Alfred as well?
Want to see if you can dial in?
I can dial them in through that system if you give me. I can.
Do we have 7?
Dr. Berdeur does not count as part of your quorum, correct?
You count to us, though, Mike.
You do.
See any cars pulling into the parking lot? No.
Urgent care center down on the corner. I can grab somebody.
That's right. That's right. All right, we'll continue as a non-minutes meeting, or at least if non-quorum, but why don't you just take some notes that will be notes, not minutes? How's that? Since we can't officially authorize minutes of a meeting that doesn't really exist. How's that sound? All right. Dr. Mao apologizes for not being here. A couple of interesting pieces of correspondence I want to share with everybody. The first is, and I'm going to ask Mary to comment on this a little bit. There's a note that just went out from the Department of Health, Bureau of Narcotics Enforcement, regarding Section 80.136. Rich is probably the only one that can rattle that off by memory, which authorizes ambulance services to purchase, possess, deliver, administer, and safeguard controlled substances. I'm not going to quiz you on it, Rich. Don't worry.
Thank you.
You're welcome. Mary, would you just highlight the contents of this to the people who hold the licenses?
As part of getting the alternate formulary approved, which Dr. Daly loved so much, the last piece of that was having this sent out, which allows Class 2, 3, and 4. Previously, all agencies were Class 2 and 4 for narcotics. We're blanketly mailing all agencies a license, a brand new license that lists Class 2, 3, and 4. However, if you do any substitutions or need to make changes to your plan, you still have to notify us of them. The other thing is, if you could return your old license to us, to the 875 address enclosed in the letter, just for us to destroy and mark that they've been returned.
So basically the goal, Mary, just is so that we could include ketamine on a formulary if someone chose, or in a plan if somebody chose.
Correct. They would not be able to use it till they have had their plan approved. But this will expedite the process as opposed to having to.
Okay, good. And it's one standard license then that would be used statewide. It
Yes.
still doesn't include heroin and marijuana, right? Okay, good. But those are both ones, right, Mike? Okay, good. Our pharmacist down here is affirmed indeed those are
And
ones and
originally
not
there
covered
was
by the
a-
license.
If you remember, originally it was supposed to include Class 5, but we could not think of a Class 5 narcotic that would be therapeutic on an ambulance, even with substitutions. So.
Michael?
Not that I can think of.
No.
I'm surprised it wasn't in this fabulous piece of work put out from the state.
But I had nothing to do with that. I was just trying to streamline the process for the providers, was my only aspect.
Well, thank you. And Mary, thank you for
I just
bringing this
wanted
to our
that letter
attention
went out to
today.
the agencies. Dean emailed it yesterday. Some agencies received them today. It didn't go out through the Remacs or medical directors, but I just wanted to make everyone aware of it, just because you guys' names are on the licenses.
No, thank you very much, and we should. And actually, Dean, if you do me a favor, let's make sure the staff here sends it out to all listed medical directors for ALS agencies, because frankly, we need to know what's happening with these licenses. Not that, frankly, most of us would be able to rattle off the drugs appropriately without calling Mike first to ask him what they, exactly what the drugs in each section really are. But the important thing that comes with this then would be the advisory that was issued that Mary refers to, which is the policy from the state on drug shortages and drug substitutions. There is a regional policy that we issued last year on drug substitutions that still holds true. If you are going to do anything on an ambulance that is outside, or on an ambulance or on a response vehicle that's outside the formulary that we've established regionally, you just have to notify us here so we can review it. All right? And if there's anything that's going to require a drug substitution with a drug that's not currently on our formulary, we would need to deal with that regionally to make sure that there's education that's going out that's appropriate. All right, that hasn't changed. There are a number of drug substitutions that become very complicated when you look at the statewide advisory, and we've worked our way past some of these things in the past. Some of these things are a little bit more complicated. We'll have to deal with those, hopefully, if they come to fruition. Hopefully everything will work out fine and we won't need to deal with them. All right, and Mike is going to serve as our guiding star the whole time, making sure that we're being safe for our patients. So, thank you, Michael. We got correspondence that you should all be aware of from a woman by the name of Whitney McGee Phelps, who has a son and a husband and a daughter, both of whom have Addison's disease and adrenal insufficiency. This is something that came up to the Remac about 2, maybe 3 years ago, with a request for statewide protocols for the use and carrying of Solu-Cortef on board ambulances. That at the time the Remac deferred to the regions. What I answered this letter with was that we won't be changing our protocols on a regional basis without working with our collaborative partners. That change will be happening in 2014. We're going to explore how the adrenal insufficiency has been approached in different regions and bring that back to the collaborative protocol group to see whether or not this is something of use, something that is potentially helpful, or something that has caused any controversies or drug errors over time. There certainly is an active group who would like to see the treatment of adrenal insufficiency be brought to the pre-hospital environment. So far, the commentary from physicians that I've asked about this and pharmacists ranges from, if the person's in crisis, give them Solumedrol and fluids. That's enough to temporize them until you can get them to the hospital. We have not yet approached the endocrinologist for their opinion, and to the best of my knowledge, the only cases that we have had regionally have been dealt with a medication assist by EMS offering to give the Solu-Cortef that the patient already has. If a patient is ill and on their way to adrenal crisis, they feel lousy, they're at home, not at work, and they have their Solu-Cortef there with them for the most part. So it's kind of an interesting problem to decide what the best thing is and to control our signal to noise ratio.
Is there a teaching component that they do with these lay people? Because like even when you have a child or a family member who's diagnosed with type 1, they're put on insulin, they go through the whole thing with glucagon with the family, so.
Probably.
Okay.
And there certainly has been some education that has been available out there through the groups, and we've offered the opportunity for them to do education for providers as well, because I think the education is the most important part. Part of this that they talk about in an email to me is a disaster where this woman's husband actually was in adrenal crisis. He had had a flu. He couldn't keep his oral hydrocortisone down. The EMS providers were told about this condition. The ambulance didn't give him anything. He got to the hospital. He ended up in a hallway for a couple hours. He never got his Solu-Cortef. We've done this before where, because of failings within a hospital, we've created things in the pre-hospital environment. Waveform capnography comes to mind, where we've done a great job of bringing that into the hospitals through the field. I'm trying to get more information on that so we can correct this wherever this happened to have occurred. I suspect I know where it might have been, but we'll see if we can find any of the information there to find out what actually happened.
So the medical director for the agency that covers the area where they live be able to in-service the paramedics that serve that area to make them more aware of adrenal crisis and be able to do the medication assist?
We've approached the patient, or actually the spokesperson for the patient, to ask her if they would be willing to do some education. If they don't have anybody that can come forth and do that, we'll make sure that does occur, because I think that's profoundly important. At least to know, identify, and be able to identify that when they get to the hospital 11 minutes after they've been picked up by the ambulance.
Yeah, they live way out.
Way out there. Somewhere between you and me, I think.
Pretty much.
So we can get them to the hospital as long as we make sure to pass the right information along, which sometimes is the most key component of this, I think. We want to make sure we're taking good care of our patients. We want to make sure we have the skills. But I want to make sure we don't lose any of the educational things that we've been doing with our providers with a new disease process and new drug, another drug that might not get used in the box very often. So I'll keep you posted on the data that we get back from the regions that instituted any programs. Any other questions or thoughts on that before we move on? Okay. One of the things that we've asked the nurses committee to explore is how public safety answering point notification and hospital notification process goes, particularly when CT scanners go down. We'll keep this group notified as to what the nurses committee works on with that. And let's see, quick note from, this one's from Scott Bowman, who says he's in Nevada. We'll add to it that Dr. Duthaler is in Florida, so there's places that are nice and sunny. We'll note that it's beautiful and sunny out here today, although a slight bit chillier with less umbrella drinks. Don, would you like to lead us through a discussion of what happened in academic?
Academic, most everybody was here, but for the folks who weren't, drug shortage update, Mary, I don't know if you want to mention anything from the state that was all sent out there.
I'll just reference the 11-page policy statement.
But there's a policy that came out that folks may want to look at. Yeah. We discussed signal criteria, and basically the decision was that a signal is anything that's invasive except for fingertip requests. Basically, that's what will be sent out. Membership was basically put the rest, as we discussed that. Versus dosing, it was noted that the Breslow tape is actually only has one dosing, and that's for induction. It doesn't talk about seizures, and that is a bit of concern. So an advisory is going out specifically to say don't be using that dose. Use the dose that we have. And Mike, I don't know if you want to mention anything about your thought of replacing the Breslow tape with
It's probably a good time to do that. I had a conference call for about an hour and a half yesterday with somebody from ebroslow.com. The Broslow tape itself does not in any way, shape, or form include Dr. Broslow anymore. It now is owned by GE Healthcare after a number of different shifts over time. The Broslow tape, I haven't been unable to get in touch with a person there who would be able to discuss the idea of customizing it to the drugs that we actually use in the field. ebroslow.com connects to a system called Artemis that I would suggest to all of the ER docs take a quick look at that system and how it might actually help in the care of your pediatric patients. There's also a app that they have that I'm going to send you a link to called Safe Drugs. Or Safe Dose, excuse me, both of which allow you the opportunity to dose children based on their weights for appropriate medications. What they're now suggesting and selling is a length-based tape that instead of having everything written on the tape where it gets very small and difficult to read, you measure the child with basically a tailor's tape. It's a sort of reinforced cloth tape with color markings on it, measure the child out on that, and then refer to a laminated PDF card, very similar to the things that Mike was working on, however, done commercially. And frankly, I think it's basically the version C, I think, that of what we're looking at.
You had sent it to me, and I thought it was a great product. I don't know how cost prohibitive it is, but one of the things I liked with it is I thought it was easy to understand. It had the dose of the medication and also to the volume of the medication, which personally I think is probably the safest way. It's sort of double check there. So for what I saw of the product, I was pretty impressed with it.
Okay, that says a lot. Frankly, what I would like to do, and what I talked about briefly at Academic, is I would like to explore the option of going to the regional council and asking them for some money to support a complete regional transformation from the use of length-based resuscitation tapes that we currently have in all of the ambulances to these other tapes with laminated cards. The reason I want to support it is I don't want to make this an unfunded mandate that we're going to put upon our ambulance agencies, and what would actually be not that prohibitive, but anything once you've already approached a budget year becomes prohibitive. And we're doing this in response to a medication error without harm that we've already had brought to our attention. This will give us a chance to address it in one fell swoop. And frankly, what I would bring to the regional council is this is exactly why we should have the ability to budget funding for things like this, so we can make changes like that and support provision of quality pre-hospital care. This can't be a motion because we can't take a vote, but I can certainly take a reasonable tide from the group to suggest whether or not this is something you think I should bring forward to the council. Is there anybody that thinks this is a bad idea? Okay, I'm just trying to think if there's anything I'm missing, because I can't think of any downsides myself, and it just seems to be something that just plain makes sense to get cards that we can read the information off of, ultimately put it in the protocols if we can, so it's there as well, have these length-based tapes that are out there and easy to use. It just all seems to kind of fit together. It would also be the same information that would be there for docs in the EDs, so there wouldn't be two different things they'd be working off of. And it would all be drugs that are on the formulary. Does it all make sense? Okay, perfect. I will carry that forward to the council. All right, Don, anything else?
Just the listing of courses that are available on the regional website.
Okay, cool, thank you. No CMAC or SEMSCO meetings, although CMAC and SEMSCO still exist. So that's an interesting change from where we were, last month. So we'll have to see where when meetings come available. A couple of noted disaster life support courses that are mentioned here from the HOC, and some OR and ICU fire drills involving surgeons and anesthesia. That sounds really scary.
It was.
It was really scary? Okay, gotcha. Lots of people racing
In a small
area?
yes.
Okay, gotcha. That sounds scary. Okay. Agency updates and upgrades, BLS albuterol for Skidmore and Epi for Nassau Ambulance. Narcan for Rensselaer Volunteer Ambulance. Gotta ask Mary, does Rensselaer Volunteer Ambulance exist at this point?
I'm surprised to see that listed here. They still have the,
You have a quorum.
yeah, they
Excellent.
still have a, they're still listed as an agency code in the medical director. As of yesterday.
If I may. When
Oh, here we go. We'll get a clarification from staff.
they came through, their ambulance should be just about back in service. We called the state said that, yeah, they're still in service.
Okay.
One ambulance was burned out completely. The second one is, they're just getting back from paint, so.
Oh, okay. Gotcha. Thank you for the update.
Yep.
And with the addition of Dr. Bosco, we now have a quorum.
Sorry for being late.
Thank you for being here. Appreciate it. Where shall we start? We can go back and approve our March minutes now. Dr. Dueno. Motion to approve?
Sure.
With a second, please, from Dr. McHugh. Thank you. All in favor? Excellent. Thank you very much. I will bring Dr. Bosco up to speed on individual items. One thing that we just spent some time talking about, Sam, and I'm sorry to hammer you with stuff as you walk in the door and find one of Sarah's cookies. But
delicious, by the way.
we just spent some time talking about pediatric resuscitation, the use of the Broslow tape, which actually has a lot of medications on it that we don't have on our formulary, and one in particular, which is midazolam, which doesn't exist on the Broslow tape in the dose that we use it for seizures. One of the options that's out there is actually a color-based length or a length-based resuscitation tape with similar color markings that would be tied to cards that would be commercially prepared with the medications only available on our formulary. And the motion that I had suggested to the group and we had talked about but had not been able to vote on was to approach the council to seek funding for replacement of Broslow tapes in the region with these length-based tapes and cards appropriate to the length-based tape that would allow easier drug reference for our providers as well as for our physicians in each of the emergency departments.
So who prepared those tapes?
ebroslow.com, oddly enough.
Okay,
Um,
I'm fine with that.
Okay, thank you. All right, can I have a motion to that effect, or, thank you. And I'll take the others as a second. Thank you very much. All in favor?
Aye.
Okay, we'll approach the council with that. Thank you. Upgrades do not need our votes. Public access defibrillation, that's all notification. Staff has reviewed an ALS upgrade or ALS credentialing program for community and says that it conforms with all of the other credentialing programs that we have. Public access defibrillation, Sand Lake is putting one in their building, or two in their building, excuse me. Scotticoke Fire, Niskayuna Internal Medicine, Golub has 3, and the Galway Central Schools 6. New business, public safety answering point and hospital emergency notification, which is going to really start through the nurses committee because they involve more communication on a daily basis than the physicians do. Once they come up with a plan, we'll bring it back here and see what they have to add. But the goal here would be to get as much good information out to agencies as quickly as possible. We still have to find a good pathway for doing this. One of the things that was mentioned earlier is we don't have the ability to poll hospitals the way we used to in the past across the intercom, the radio intercom. So what is our new pathway to do that, and how can we make sure that other hospitals know when a hospital is doesn't have a CT scanner, for example, and which ambulance agency should know that a patient doesn't have option of a CT scan at a hospital, and how to get that information out as efficiently as possible. So that's something that will come back here. Two things that I wanted to bring up. The first is the eBroslow that we just talked about briefly, and Artemis. I will be sending links out to everybody so you can review those and take a look at the information to see whether or not it would actually serve you well in your emergency department as well. Frankly, I think the product looks like it's going to be something that will work well. The SafeDose.com or SafeDose app is something that's actually available for free now, will remain for free if you have that initial link, and will then disappear sometime after a month or so from now. So it's something to pick up now. I need to apologize. We were going to originally do an MFI review today. Unfortunately, I didn't remember we were going to do an MFI review today and did not send out the template to all of the MFI agencies. We will do that in either May or June, depending on my response from the agencies involved, to make sure that they can be here and can share data with us about how their MFI programs are going. All right, I want to make sure that we're working with them, though, and not hitting them with something that would be a surprise. We did have a question on MFI. Joe or Art, you guys want to talk about it real quick, or Brian?
I guess the question was what does the committee want to see in a formal proposal? We can, Clifton Park and Malta are interested in moving forward and riding on the coattails of the Northern Saratoga County MFI program. That being said, in our application process to the MAC, we can, and we do have a tendency, we said this, to submit 30 pages of documents. Obviously, you guys don't want that. What would you be interested in seeing in an application? I guess how in-depth?
To give you a little bit of history on it, northern Saratoga County, which encompasses agencies Wilton, Monroe, Corinth, and Schuylerville, have proposed and were granted a mutual aid RSI program, probably 2007 or so, if I remember correctly, right around that time. They've had a very successful program with very little negative outcomes and very good quality assurance and data collection. On the southern tier of the county, which encompasses Malta and Clifton Park, both of whom now have a significant call volume, looking at a combined call volume around 6,000 calls a year. We don't have any capabilities for this. We understand all of us are RSI credentialed through other agencies and have a significant amount of experience with it. We understand the significance of having this in our toolbox, as it were. We feel that it is something to be used very cautiously, but it is effective when necessary, and sometimes it's the only option when you have those high acuity patients and we need to secure an airway. So we feel that by joining the current program and utilizing our agencies, we're able to essentially cover the entire county, because those agencies who are not going to participate or haven't been participating border all of us in one way or another. So we actually have a system that will be effective throughout the county, therefore essentially creating a county-wide system. We don't want to reinvent the wheel. This is not the first time that the MAC has heard this. We want to provide you with whatever information you want to ensure that if you approve this, you are comfortable and confident with our abilities to provide this service and to have good, solid oversight and a strong educational component to it. So I guess what we talked to Dr. Daly beforehand to see what his impression would be of what we need. And he said essentially, you know, let's bring it up for discussion, field any questions that come up, anything that we can answer for you now, and we'll put together a quick but hopefully efficient and well-rounded presentation for the next MAC for approval to move forward. I spoke with Dr. Duthaler, who I did actually tell him it was 35 degrees out and that I hated him, earlier today to make sure that he had buy-in into the program, and we had discussed this previously, doing this without success in that the neighboring agencies at the time were not prepared or willing to participate. He still is on board with it. As many of you know, Dr. Duthaler provides a solid and strict oversight for our organization, and you know, feels that our providers are capable. We will obviously have a credentialing process. Not all of our providers will be credentialed. We'll be very selective on who is able to do this, and we have strong quality assurance through EMS charts and other means that we'll be able to monitor this closely. Anything else? No, that's pretty good.
You know, also, you know, one of the other things is there have been times, I don't know, Nash, if you can speak to it, but talking to Moreau coming south when the aircraft wasn't available and not having, you know, two credentialed providers, that now coming southbound down to the Met or something, that they'll actually be covered and actually be able to utilize the mutual aid and additional resources.
Yeah, it really would provide a little different lifeline and impact some of our on-scene and transport times in the north with some of the fluctuations on availability of aircraft and so on and so forth, with our transport of trauma patients to the Med or, you know, neurological events patients to appropriate facilities. So if they do need that airway management, especially on hours where my agency in particular doesn't staff two providers and they are going to one of the southern hospitals, it's a pretty important link where in the past we have utilized you know, two providers from Colony or two providers from Guilderland in addition to our provider in order to ensure that happened for improved patient outcomes. So it really would add another link to what we do in Saratoga County.
And realistically, if somebody were to be, you know, heading south on the Northway, we all have direct access to the Northway. And if you were somehow, by some strange coincidence, unable to hook up with anybody, by the time you got to the last agency, you would be close enough to the hospital, it wouldn't matter. So really, by the time you got past Colony, if you weren't able to hook up, you're within, you know, striking distance of an emergency room. Or you can have the option to, you know, head, you know, down 7 and hit Samaritan if necessary, or whatever. So that would actually play into our critical thinking element and designing the program and making sure that our credential providers are well aware of circumstances like that, you know. Is there any questions? Does anything just pop to mind immediately that we might be able to answer?
If you folks aren't gonna reinvent the wheel, I would probably just mimic the program that they're using up north. I mean, it's a good one, so.
That's our intention. The only thing we would want to add is to show definitively how we will be able to essentially encompass the entire county and have a service that is you know, can be effective for pretty much everyone in the event. So as I said, you know, even those agencies who aren't participating will have the advantage of being able to utilize that resource, you know, in the few times that it's necessary.
Brand new ground for us. We've never seen the expansion of an existing program before. So I think, you know, frankly, I would say keep it simple. Give us a good, concise presentation of exactly how this is going to go. It'll tie well in with the report on how the program is already going anyway, and it can explain or really answer some questions from that as to how it could assist. So let me do it right there.
We'll work closely with Nash. Nash has a strong grip on how all this works in the northern tier, and we've reviewed a lot of his material already, and it's very effective, very efficient, and easily can be utilized by our organizations to affect the same, you know, result.
I just have to throw this out because I really like what you're doing. What you're doing is a value-added approach instead of a volume approach. You know, our old school thinking 10 years ago was, you know, give everybody the ability, and now you're thinking in terms of the value-added, add a little bit and cover it regionally, which I think is great. The other great thing you have in your pocket is you're using providers at heart to work in other places, which is proven a success by Albany County Sheriffs. The only question I have is when you do hire some new medic who may not be involved in these other programs, how are you going to educate them? Which I'll ask you when you do your formal presentation. So if you can just address that, what are you going to do with the newbies?
I think we'll discuss in detail our credentialing process and what will be required. Not everyone will qualify. We spoke at length. You know, and several factors will be taken into consideration, not just length of service or time on the job, but several factors will be considered before credentialing somebody. And I can assure you that the educational component will be arduous. Only those who truly are qualified will be able to do it, and only those who treat it with the respect that it needs and deserves will be able to provide the service.
I think Brian touched on something important with the education. We're going to be expanding, they're going to be expanding the opportunities for the providers to get their semi-annual trainings that they need, as well as more opportunities for initial education. So you know, as we bring more providers into the Saratoga County system, we're increasing educational offerings for appropriate people into this program, as well as continuing education. With collective efforts, we may be able to offer and do some different competency type stuff rather than, you know, the scale at which we can do it now.
Our backup plan was also to bring Glenn back from the last one.
Perhaps these are those things you might go for.
Nice. So, that'll be good. I'm looking forward to seeing that. And if, for example, if there's a change in the date from next month for MFI, I'll let you guys know sooner rather than later. All right. Couple of other things. First, there will be a Remo Protocols app that will be built and available out there. It will be modeling an SREMS app that's currently available out that Susquehanna built. We basically will be working from that. Nash's motion and the council put forth some money in order to support this. Basically what it's going to allow is everybody to carry the protocols on their smartphone, but labeled with our protocols rather than the current ones that many people are carrying, which are Susquehanna's protocols. So they're actually both the collaborative protocols, but it should have our label on it. and we're actually going to update it to have our medical control facilities available through there as well. It's a neat app, relatively simple, and it'll be nice for our providers to have that available to them
When do you expect that?
within the month.
Will you be able to index it so they could hit that
Yes.
index thing and go directly to that thing?
Yeah. If you want to see how it works, actually, one of the guys, Nash, can you show Dr. Doyne how? If I was really smart, I could probably put it on the screen behind me, but Chris hasn't taught me how to do that yet.
Correct.
Actually need my iPad.
Can you show him how to increase the size of the typeface too?
It's pretty big.
It's big enough, even with these glasses.
It's out there.
What?
Part of a good patient.
What's the cost gonna be?
For the providers? Nothing.
So the, on the App Store, or how we?
It'll be through the App Store. Through the App Store. Again, and my apologies, I don't know what the equivalent for Android's going to be.
But it will be there.
I don't have an answer for that yet. So if we don't have one for Android, my apologies, but for 2014, we'll build one thing that'll work across the board for both. So.
You are a member of the Apple Mafia, I know.
What?
You are a member of the Apple Mafia, I know.
I don't think it's actually the mafia. It's more like a cult, I think.
It's a call, it's
Yeah.
definitely a call.
You'll kill people.
True. Physician credentialing. I hope you all got the quick note. Originally, I planned on splitting into a couple of groups and coming up with some ideas. Basically, we're a small enough group right now that I think we can probably hit this just from a larger group. Did everybody come up with about 5 things that they thought were going to be important as part of a physician credentialing program? And did I hit all of the different potential types of physicians that we might get locally? So the board certified or board eligible EM trained doc. Let me get my list here. Board certified, board eligible, EM trained, EM boarded, but FP or IM trained coming into the area, or FP or IM working in an ED. That's probably going to cover them all, right? And
It covers them all. The question I had is, do we really still have some FTIM that are not board certified working in ED?
yes,
Yeah.
we do, as a matter of fact. We do. And we have them serving as locums physicians in multiple cases.
We need to include pediatricians. Do you have pediatricians in your
Not that would be answering that every invest. They're all emergency medicine adult.
Yeah, and we've got a couple of pediatric trained EM, peds EM boarded folks, but they don't do any medical control for us. No consultation review. So what are some of the things that you guys came up with that we should build into this? Because this is something that's become an issue, and now we just need to get it done. We just need to have a training program. I suspect something that's a brief orientation for the board certified, board eligible person who's gone through EM training, maybe a little bit more for the folks that don't have the EM training. When we talked about this about 5 or 6, now probably 8 years ago, we wanted these guys to go out and do ride time. There was a certain number of hours that we wanted to make sure that they were actually out there on ambulances, experiencing what it was like to be a provider in the region. The reality is that when our institutions need locums, they're calling an agency, they're getting locums docs. We're lucky if we can get people to know that we have protocols, much less to have read the protocols. And we're actually going to go out and certify this training program so that people can get Category 1 CME for participation in it, so that we've got that carrot for them to do it. So there's a reason for them to do it. Sarah?
One of the things that they definitely need to know is what drugs are being carried in the field, but right now that's a moving target.
Mm-hmm. Not a grossly moving target, though. The answer is we don't carry lorazepam, right? And that's the most common error that we have with, in terms of docs asking paramedics to push stuff. They do that all the time. It drives the paramedics batty when our docs tell them to do that. Bruce?
I made out my little list, kind of overwent more than 5, but I noticed something after I wrote it out, is most of what I was writing was really not medical in orientation, it was mostly process. The first on my list was RMAs, again, it's not really medical, but it's sort of how we do RMAs. Our concept is securing on the scene, how to handle a physician on the scene, or if you're in a doctor's office, how to handle that sort of disagreement. The things that we get phone calls for, I will find the vast majority are not truly medical. They're either meeting a protocol or calling the doctor to say the sugar was 30, it's now 140, and they're fine. Can I go home, please? And then it's these other things, you know, how do you handle the STEMI? How do you handle the therapeutic hypothermia? What hospitals do that? What ones don't? So I just throw out there, it tends to be more of the non-medical aspect. It tends to be more process. And if you want, I can just read down my list. I want to dominate the conversation. A few of the things that I just came up with.
I think you're dominating the conversation right now. It's a perfectly good idea. You got a great list here so far.
All right, so the first one I had was just RMAs in general, sort of what, when, and what the physician needs to know is to speak to the patient directly. Don't just work through the paramedic, because that one-to-one direct conversation via the cell phone is magical. As soon as the paramedic hands the cell phone and says, Dr. Ushkow's on the phone and would like to talk with you, I'll go. I don't even say
Please don't make me
anything.
talk to him.
That's right, amazing. How to handle the hypoglycemics, which actually I'd love to even delete out of our protocols. I think we do it so well now, and the paramedics are so good with it now. I really don't have to hear it, because the presentation has now been so condensed. Sugar was 30, I gave him sugar, they're awake, they have a meal, somebody's gonna watch them, can I go home now? I hadn't said anything yet, I hang up the phone. I think we're ready to drop that one. I think it was good we did it for a while, we're done. Orders to secure, MD on scene, interaction we talked about, or in the doctor's offices. Controlled substances, especially as we move towards ketamine and other things, that have to know what we do and how we do it. Transmission of EKGs, and also STEMIs in terms of center designations, same with stroke, therapeutic hypothermia, pre-hospital therapeutic hypothermia, more as a reminder, as scared paramedics call in and sometimes forget it. How to flag for QA. You have a call you want to bring up, or they did something very well, or did something not as well. And also stuff with the copter, when to call, when not to call. If they're in Clifton Park, maybe the helicopter is really not the most appropriate recommendation. Or if they are very far away and it's a snowstorm, maybe it's a good idea to think about. That was my list.
I would think that the major thing is what drugs are available. I mean, that's a major complaint I've been getting from you docs. Essentially, they ask me to give Tylenol, they ask me to give Tylenol. I mean, the main thing needs to be, these are the drugs, this is what you can do. I mean, the practice is, I think, basically the same. And you're going to find more people who are interested in EMS and some that aren't. The ones that aren't, you're not going to train them in 2 hours. So I think mainly it's, you know, what you can actually give out there is what they need to know to keep confusion down.
I think including, if you do the course, a list of, like you said, which hospitals offer hypothermia, which hospitals offer cath, what hospitals offer them. So they, if they ask where you want us to go, you at least have seen a list. You just move in the air, you don't know who does what.
It's a good idea. Very good idea. Steve? Sam, anything pop in mind for you?
Yeah, you know, I thought about, I think Bruce's comments are really good. I wasn't even thinking along process. I was thinking more along the lines of orientation to what our medical protocols were for new providers. But I think Bruce's approach is excellent, actually, the more about it. But I do think we still have to include the provider signing off in some way that he or she's familiar with our protocols, you know, and that's got to be part of it in some way. And I thought that your memo with regard to the gradation of training is appropriate, because I think a lot of you know, a residency trained person has had time in the field as part of their residency. They don't need to have time in the field again.
Mhm.
And I don't think we should be requiring that for someone like that. You know, so, I don't know what the right formula is, you know, but I like these special situations. I think it'd be good to have them documented.
Mhm.
It would be good for everyone in the region to review those special situations, or the people that are already on board, you know.
Well, if we set this up as an hour of self-directed distributive education that then ultimately grants an hour of Category 1 CME, it's something that you can then use for your own in-hospital credentialing or whatever other processes you go through. This has to be more of a carrot than a stick, because frankly, if we tell anybody that there's a stick about doing pre-hospital command, the answer is going to be yes, so what? We won't do it. And our goal will be to get people that are coming into the region just as per diem providers to get their chiefs at whatever site to send them this link and have them do it. We really need to do that. And this is something that has been an issue in Mountain Lakes in particular as well, because they have a lot of per diem providers coming and going in there, and some of this is basically crossover that would work well for them as also. So some of it may end up bearing some fruit for them.
Like you're
So-
planning to do this on computer.
What?
You're gonna do a computer on?
Absolutely. Do it on the computer, allow them the opportunity to do some testing on the computer. At the end, have it print out a certificate for them. Run it through the CME process through the medical college, which is arduous at best, but frankly, I think is frankly going to be worthwhile because it's the only way we have something to give back on this. So, Rob.
The first screen is EM trained, not EM trained. The EM trained ones go straight to the protocol. These are the services available. The non-EM trained do a 2-hour, which is, the first one is, this is EMS, this is what we do. And then it goes back an hour of that, and then it takes you to the 1 hour that the EM trained did. To kind of, the EM trained guys that do this before, I just need to know what's appropriate locally, and the family practice and local attendance up further, or for us, we're not the locals anymore, but yes, please give the introduction to EMS, and it's not too onerous, it's an extra hour, but they also get credit.
Someone's gonna have to be double checking the Remo base, whether the person is honest about whether they're EM trained or not. You know, we usually have their CVs, right, for,
No, we get CVs for medical directors. We don't get CVs for every physician that becomes a medical control doc.
all right, well, I guess you can still.
And the other question would be-
At the DOH website.
But the other thing is, you know, you've been practicing in emergency departments, doing medical control in your various sites, and you're 20 years out from your internal medicine residency. It's going to be awfully hard to get them through.
No, I think
2
that
hours.
scenario should be for new docs coming.
If you're here,
If you're already here, it should be the 1 hour scenario. So I think the 3 categories are we gonna mandate recertification or whatever we're calling this, reorientation by existing physicians? Is that the idea?
I think if you do that, you're gonna get a lot of pushback.
I think you will too.
I would like to see alternate states.
I mean, I would make this for new people coming into the area. I don't think we should do it.
Well, we have an existing
For
problem.
15 years, we've been doing online medical control.
Yep.
From what they're gonna get.
I agree with you, but some of the things that Bruce brought up, I think would be good for everybody, but.
You think
But
you'd
I
get-
do agree with Don.
Well-
I think you're gonna get a lot of pushback.
We probably would, but do you think you'd be able to get your guys to do a half-hour module, 15 minutes? Because really, we could probably
As a
knock most of the
one-time
stuff.
scenario, yeah, I think we could.
What about 15 minutes once a year?
You're mandated stuff from the hospital.
Right.
You just tie it in with that as a half hour, 15 minutes. A shortened down version, for the I've been doing this for years, and then the full version for the coming into the area.
what if after it gets developed, you had some type of flip chart or something to put with the protocol book at the,
Yeah, no one's gonna look at it, frankly.
Honestly.
Right.
I mean, you could tie it in with protocol changes when we do those every 2 years. I mean, that would probably make a little more sense, so we can always look at the new protocols that been doing this for a long time, and give them credit for that.
Mhm.
I mean, as it is now, we go, okay, here are the new protocols, guy, look at them. Who does that, basically? I mean, it's probably driven more by the medics and the docs.
Actually, that's a good idea, kind of making it mandatory for everybody when we do a new protocol book.
Mm-hmm.
I think that's appropriate, because everybody needs to get familiar.
We've done that each time, actually, that there's been some type of mandated education. It hasn't been, shall we say, particularly successful. I've put a bunch of miles on my car and eaten some stale bagels at a bunch of different faculty meetings over the years that have been profoundly poorly attended in order to discuss protocols. Something that I will never hesitate to go do again, because I think it's the kind of thing that just getting to know people face to face makes these things all work out much better. Certainly for any of these things where it ends up with a complaint that needs a phone call or a source patient testing that needs to be performed, all of a sudden it's much easier to do if you know somebody. So I think that's something that we should continue doing. But the self-directed education done through a chief may be the easiest thing to do. But
I think the new doctor thing is pretty straightforward. I think EM trained, non-EM trained,
Mhm.
1 hour, 2 hours. I think the existing docs and bringing them up to speed on anything is open.
Mhm.
I don't have the right answer.
But if you're already doing it, do it online. Offer it.
Mhm.
I mean, you can get somebody to do probably a half hour without, or an hour. Push them much beyond that, you're gonna get pushback from the guys.
yeah.
Especially if it's not an annual thing. If it's, kind of a one-time thing for a reason, I think people will go along with it if it's less than.
Okay. Brian?
But just having done some of the MSN services for the residents, one, especially for the new docs, have some voice, digital voice things on whatever the training is on different versions of radio reports. Some very, grade A, high caliber paramedics who give 10-second radio reports and tell you everything you need to know. The other group that kind of knows what's going on but really isn't sure and is looking for some direction, and people who are like, oh my God, tell me what to do. And if you've never heard it before, and the first time you pick up the radio, you don't know who you're going to get. So maybe, at least having heard some of that, and you probably don't want to just take it from an existing radio report because somebody's already interacted with that person and changed their direction. But if somebody wanted to just sit down and give, 4 or 5 different versions of even the same call, just so you can hear the variation in how the radio reports go, because some medics are very good at it and some aren't. And some very good medics aren't very good at giving radio reports, so just to give them a sense of what they're going to be dealing with before they have to.
Would anybody be disappointed in me right now if I didn't offer Brian the opportunity to do that project?
But I sat here going, I shouldn't even say this.
and then have Glenn call in and tell him.
Yeah, I'll have Glenn do it.
I think that
I'll
sounds
do
like
it. If you want me to do it,
a really good idea. Really good
The
idea.
other thing you should add is the NARCS log.
Narcs log.
Yeah.
It's an excellent idea.
That's so highly.
We'll discuss that later. Ken?
What about the DNR and the MOLT process?
Make that all part of the
I had
securing.
a doc this weekend who wanted to know why I couldn't take a verbal DNR from his son, saying, well, why didn't you accept that? Well, paperwork.
Now that I'm talking to you, we can work this through. There you go. Okay.
Just one question. For the sort of renewal for the experienced online physician people, although I like the idea of being able to do it online, what I've done, and quite successfully actually, is every year I do a review of the protocols at our staff meeting, and that is well received. because it's just, they had to be there anyway, and it's just, they're listening to my reports about other things anyway. And that goes over fairly well, and you have a contained group of people. If you force that same group of people now to have to do it online, I think they're not gonna do that. So I'd like to be an either-or option. Some hospitals may be able to operate better on an online system. I certainly know for my group of docs, it'd be much easier for me to tag in an extra 10 minutes in my staff meeting.
Makes sense. Makes really good sense. And frankly, we've got such great participation here. The hospitals that I've gone to have been some of our peripheral hospitals that have been less so. So.
Is it worth trying to do a one-time roadshow to all the hospitals?
That might be very, very difficult to do.
Okay.
Might be very difficult to do. It's an interesting idea.
Or a roadshow here? Bring them to here?
No.
And do it one day?
No.
No? Okay.
No, you're not getting them here. Nice idea.
Steak.
Steak wouldn't do it. Steak wouldn't do it. All right, old business, signal criteria. Don, what exactly was the motion that ended up passing at academic?
The exact motion, Howard, do you want to read it back since you have it? That's probably easier.
Just a second to pull it up, I'm sure.
This is a seconded motion that comes from the academic committee on the definition of a signal.
I just want to read exactly what was down there.
Okay, motion by Brian Taft, seconded by myself, that a signal is to be defined as any invasive ALS procedure by a regional ALS provider with the exception of blood glucometry. And passed unanimously.
Does that include injections of medication?
Yeah. Anything is the same.
Any ALS invasive procedure with the exception of blood glucometry.
Stick it in, it's invasive.
This is a seconded motion coming forward. Ignoring whatever's going on to the left-hand side of the table. All in favor? Or any questions?
Yeah, I
Bruce?
have one question. So if someone pushes some intranasal medication, but just intranasal, is that a signal or not?
Yes.
It is.
That is.
Yeah, it is.
Because it's entered into the body.
Rich?
I'm probably way out of line here even bringing this up, but I'm going to take.
But at least we know you'll be polite.
I will be polite, I will try to. Yes, should you perhaps add the word pre-hospital to it, to your motion? Because we do a lot, we provide a lot of invasive care interfacility, where the remote physician may not be involved in the care at all. It's between the sending and the receiving physician.
Oh, this was just about getting a signal number that had nothing to do with whether a physician.
No, but the way this definition reads, we might have to call for a signal every time we take somebody from Albany Med to Mass General.
Correct.
With 3 drips hanging.
Correct me if I'm wrong, Rich, but doesn't that fall under outside of Article 30 and therefore not the purview of the region?
This isn't talking about.
I know, I'm just concerned about the.
It
I
is
think
Well,
adding the
getting run
adjective-
numbers for no reason.
Adding the adjective pre-hospital, I think would solve your
That's-
problem, just a
that's fair
friendly.
enough.
I think that makes a lot of sense. I
Cleans
think
it
the,
up.
the confusion becomes then also what is calling for a signal, because we're not calling for a signal, we're
Right.
actually typing it in on a computer now,
Typing it on a
right?
computer, and why would
Um,
you want to consult with a ED physician if you're transferring a one physician's patient from a floor, or from an ICU at Albany Med to an ICU at Mass General? You're gonna want to consult.
Well, this has nothing to do with the consultation. This just has to do with what is a signal. So what would get a number on the bottom of the PCR?
Right.
So if we
But
want-
really, our governing body here is about the transport of patients from the field to a hospital, or from their primary interaction with healthcare to an emergency
The
department.
current definition of an EMT in public health law and an advanced EMT is one, I'm doing this, it's not verbatim, one who provides pre-hospital emergency care.
Mhm.
So all these interfacility moves that we do as an industry, I'm not quite sure how we do them. But we have for years, and I think healthcare would be screwed if we stopped.
Mhm. So we either add the term out of hospital or make it pre-hospital. I leave it to the group.
Pre-hospital. And that's the standard terminology. It cleans it up nicely.
Mhm.
And you know, that way somebody's not sure of the definition when they're logging in their thing. It is what it is.
Mhm.
Right. That's the end result, yeah.
Okay. Do we need to vote on it?
Does the academic committee look at that as a friendly amendment?
Sure, we'll be happy to.
Let's move on.
So be it.
Actually, you guys have to vote on it anyhow, right? So just
We're gonna do
make
it again
whatever
in 4
motion you
years, so
want.
don't worry about it.
4 months.
That long? 4 months.
Do with Brian's next rendition of the credentialing manual.
Yeah.
Right, I was
Yes,
thinking
yes.
credentialing needs to come up again, Brian.
Not in this century.
We're happy.
Are we happy?
Vice Chair to accept that.
Excellent. All in favor of the amendment?
It's friendly, so you technically don't have to vote on it if they accept it as friendly.
Oh.
But we can
What do
vote
we have to do
anyway
with the
if you wanna
technical
make it
error?
official.
Are we okay?
Yeah.
All right, all in favor of the amendment?
Aye.
All in favor of the motion? Excellent. Thank you very much.
Did you get that?
Anything else from the floor? With that, motion for adjournment. Thank you all. Sam?
Yeah, Mike, I need